going to do our weekly live stream talking about cataract surgery and different glaucoma surgeries. In this series, we've so far covered a few cataract cases. We've also discussed the iStent inject, and we've talked about the Hydrus microstent. We've talked about doing cataract surgery with a white mature cataract. And today we've also covered the Dextenza punctal insert. Today I wanted to show you a case of cataract surgery whenever the pupil does not dilate, or a small pupil cataract surgery. Oftentimes these cases can be challenging because the lens, of course, sits behind the iris, and if the pupil is not well dilated, it can be difficult to reach the lens. You're working in a much smaller area. Glaucoma surgeons deal with a lot of small pupil cases because oftentimes patients who have glaucoma may also have a condition called pseudoexfoliation. And with this condition, the pupil does not dilate, and so it can make the surgery more difficult to do. So we'll go ahead and get started here with this does happen to be a case of pseudoexfoliation, and we can see already the pupil is really not that well dilated. Probably about a 4 to 5 millimeter pupil here. Okay. So we started as we always do. We make a side port incision with an MVR blade. I use a cotton tip sponge to stabilize the globe. We inject 1% preservative-free lidocaine for anesthesia. We spray a little bit extra on the cornea. And then here, my small pupil cases, I use an epinephrine solution. This helps to prevent the pupil from further constricting during the case. It kind of helps to stabilize things where they're at. Oftentimes with small pupil cases, the pupil will continue to constrict as the case goes on, but using epinephrine really helps prevent that. You'll see here the pupil is just a little bit more dilated than when we started because we injected viscoelastic to fill the anterior chamber. And with viscoelastic, you can get a little bit more what we call viscodilation as the pupil enlarges a little bit more. That's a keratome incision that we made. Once again, we're fixating the globe with 0.12 forceps at the paracentesis. We use a cystone blade to start the capsule rhexis. I like to make the capsule rhexis in these cases, in pseudoexfoliation cases, large. Obviously here we're limited by the pupil. But in these cases I found that one can go right up to the pupillary margin and even underneath the pupillary margin. And once you've done enough capsule rhexises, you kind of get to an idea of when it's going to run out. But I've not had these run out in these small pupil cases. I don't know if it has to do with the forces, where the iris is and how the iris interacts with the lenticular surface. But I found that you can get, up to the iris margin and underneath the iris margin with the capsule rhexis. Very important step, hydrodissection. We go right underneath the capsule edge and tent up, and there we get a good fluid wave. In these small pupil cases, we'll often get iris prolapse at this juncture in the procedure, and you can see right there we were about to get iris prolapse, but I depressed on the wound and decreased the pressure in the anterior chamber, and this decreases the risk of iris prolapse. So that was hydrodissection, and now we're going in with the phaco probe, and we immediately, as we usually do, core out a central area, and I use the same technique as far as nuclear assembly in these small pupil cases, and I find that this technique, this phaco chop technique, lends itself nicely to these small pupil cases. You're already doing this in regular cataract surgery without direct visualization, and with a small pupil case, you're already used to working without direct visualization of your second instrument, so this actually works out really well. So we've already divided this into, we've already separated out one quadrant, and you can see the nucleus rotates nicely there. And here we are removing a quadrant. You can see that it is limited by the pupil, and we pull up the quadrant, and you can see the pupil kind of being pushed out of the way by that nuclear piece. We move on, and we just remove another quadrant, and we're using our second instrument to chop here. And here we are doing another chop, and we go on to remove another quadrant. We're working obviously centrally in the central pupil, and phaco chop is a great technique for this because you can continue to do the entire procedure working just right in the very center of the pupil. And I have my second instrument protecting the posterior capsule, preventing the posterior capsule from coming forward. And we're using the phaco instrument, the phaco just to break up and suction out the nucleus. And there we've removed the nuclear material. We still have, it looks like, quite a bit of cortical material here. So I am going to use irrigation aspiration. I'm going to inject BSS through the side port. This does two things. It keeps the anterior chamber maintained and also irrigates out any pieces of nuclear material that may be stuck in the paracentesis. Now we go in with irrigation aspiration. And here we're reaching on, getting the anterior aspect of the cortical material that's still present. And here we're taking our time and just removing all the cortical material that's there. I'll sometimes go into the side port blade. Yes, here it is. This is a Charvel. And I use this to retract the iris out of the way so we can see any remaining cortical material that may be present further out in the fornix. I think those reflections we're seeing there are just viscoelastic. So here we're polishing the posterior capsule. And now I'll go in with the capsule polisher, which is basically a terry squeegee with, which is a cannula with with a silicone tip. And so we've removed the nucleus, the cortical material. We're left with the capsular bag. We inflate the capsular bag with the viscoelastic, and then we inject the intraocular lens through the pupil and into the capsular bag. This is a hydrophobic acrylic single piece IOL. And then I'm going to use a Lester instrument to rotate the IOL into the capsular bag. So basically we see, pearls for the small pupil case. Use epinephrine or Midria or whatever your drug of choice is to help the iris maintain dilation and not to further constrict during the case. The phaco chop technique is fantastic for the small pupil cases because you don't need to take the phaco tip out to the periphery like you do when you're trying to do divide and conquer or trying to sculpt. You just sculpt the central core, and all the rest of the work can be done centrally in the pupil, in the center of the pupil. Take the capsule rexus out to the pupillary margin. Use a second instrument to retract the iris if needed. Ensure you have a good height of dissection so the lens can rotate easily and readily. And those are really the main points that I have. Here I'm going back in with the Charvel instrument to retract the iris. I want to look for any remaining cortical material. I also want to make sure my IOL is well positioned inside the capsular bag. I have seen cases referred where part of the IOL will be in the sulcus space, and I have to assume that was in a small pupil case where the operating surgeon didn't see the IOL haptic that was actually in the sulcus space. And of course, with these single piece acrylic IOLs, we can't leave them in the sulcus space. So now we're just basically hydrating the incision. We're hydrating the roof of the incision, both for the main wound and the paracentesis. We're checking the anterior chamber pressure, intraocular pressure, with the back of the 30 gauge cannula. And once we're happy with what we the pressure that we're at, then we check the incisions, make sure that they are in fact watertight. And if not, then we just simply hydrate again if it's a significant amount of fluid. Sometimes you'll see a little bit of egress, then you push on the globe and you realize there's really not much egress there. I like to spend a little bit of time with this part of the procedure, kind of irrigating, making sure the wounds are watertight. But it looks like that's really about all that we got as far as the recording there. So that's really cataract surgery with the small pupil. Thank you all for watching. If you have any particular type of surgery that you'd like to see, or any kind of technique that you want to discuss, or have something you want to see going forward, please just make a comment on one of the videos. All the previous live streams are on YouTube at IMD76, EYEMD76. And if there's anything else you'd like to see, just reach out to me either through email or through Facebook or through YouTube. Okay, thank you all for watching. I hope you have a good night. I hope you found this useful. Cataract surgery in a small pupil. These are cases that as a glaucoma specialist you'll do a lot of, and it seems that that as the years go by, we're doing more and more cases with small pupil, with a large portion of patients who are on Flomax and other drugs that prevent adequate pupillary dilation. Okay, have a good night. Thank you for watching.